and in today's session we're going to discuss about myofascial pain dysfunction syndrome and internal disc derangement. Temporomandibular joint disorders are one of the maladies which have been misdiagnosed and mistreated a lot in medicine. A lot of research is constantly being carried out for the treatment of TMJ pain, but there are certain questions which are still unanswered. So as we clinicians, as we dentists, we should be aware of the treatment planning, that is the diagnosis part and the treatment planning of temporomandibular joint disorders, because most of the patients come to us with the TMJ problem. Okay, before going to any neurosurgeon, they'll come to us. And always keep that in mind, the three things are always common. TMJ pain, occlusion and cervical pain, all three are interconnected. Any of the pain dysfunction in one of the thing can cause the other. Let's start with this. What is the definition of MPDS? MPDS is a pain disorder in which unilateral pain is referred from the trigger point in myofascial structure to the muscles in the head and neck region. The pain is constant, dull in nature, in contrast to the trigeminal neuralgia pain, which is sharp shooting and intermittent. Epidemiological studies have stated that around 30% of the people are suffering from TMJ, that is MPDS problem, out of which the female to male ratio is 3:1. And the treatment, people seeking treatment are females in the age group of 15 to 40 years. There are 4 clinical characteristics of MPDS. It has a trigger point, a specific zone of trigger point in muscle, and have a characteristic distribution of pain, that is the zone of reference, and occasional symptoms and presence of contributing factors. Let's move on to the etiology of MPDS. MPDS is multifactorial in origin. Thus, the etiology is divided into 3 main broad categories. That is, first is the psychological, that is the central etiology, then the occlusal, that is peripheral etiology, and the intrinsic joint disorders. As far as the psychological etiology is concerned, patients who have psychological abnormalities, they have some stress relieving habits like pipe smoking. You can have sleeping on the stomach with the mandible supported by the arm, then bruxism, pen biting, you have pencil biting, you have chewing gums, too much of chewing tobaccos. All these activity is because of the stress. Now, because of this hyperactivity, there is generalized contraction of the muscles that is taking place. Because of this constant contraction of the muscle fatigue occurs and resulting in MPDS. The other etiological factor, the peripheral one, that is the occlusal problem. Occlusal problem can be inert or inherited, or you can say inherited or acquired. Inherited are birth defects like occlusal malformations which are present from birth, and acquired could be you have not replaced a missing tooth because of which malocclusion has occurred, or a faulty restoration or a faulty prosthesis because of high points, there is malocclusion. Now all of this causes micro and macro trauma to the temporomandibular joint, and this eventually result into the third etiological factor, that is intrinsic joint disorder, that is it affect the TMJ joint and result in MPDS. What are the symptoms of MPDS? The cardinal symptoms are 4 cardinal symptoms of MPDS, that is pain and discomfort seen in the head and neck region. There is limitation of the motion of the jaw. There is noise, that is clicking, gritting noise. There is tenderness on palpation of the muscles of mastication. Now all of this are associated with a negative history of trauma and infections. There are other symptoms associated with MPDS. Now these are divided into 4 groups: neurological, gastrointestinal, musculoskeletal, and otologic. Neurological could be twitching, tinnitus, muscle fatigue. Gastrointestinal patient may complain of nausea, vomiting, constipation. Then musculoskeletal, there will be muscle spasm, muscle fatigue. Otological symptoms could be because of tinnitus, vertigo, hearing loss, all the symptoms that patient may complain along with the cardinal symptoms. But to come to a diagnosis, history of the patient plays a very important role in MPDS. Okay, there are certain things that you need to keep in mind while you're taking the history. First is the pain. Obviously, patient will complain of pain. You need to ask regarding the nature of the pain, the duration of the pain. Okay, then the mode of onset. You should also ask the patient regarding the time of the day where the pain is the maximum. Ask the occupation of the patient, whether the occupation is stress oriented or not. Ask for parafunctional habits like bruxism. You can also see these parafunctional habits by wear facets on clinical examination. Previous history of pain. Ask the familial history, any kind of tension that is happening in the family or associated symptoms. Then we move on to the physical examination. We'll be restricting ourselves to the TMJ function and range of motion. Okay, you will ask the patient to open the mouth. The normal mouth opening is around 40 millimeters. Okay, see whether the mouth opening is restricted or normal. Ask the patient to open the mouth until unless the pain is there. That is maximum mouth opening, free of pain, you should ask. At the same time, you should also ask the patient to move the jaw anteriorly, posteriorly, protrusion, retrusion, and lateral movement. The range of motion that can be achieved in protrusion and lateral motion could be around 10 millimeters. See whether this is there or not. Check for the range of motion, active range of motion and passive range of motion. That is, you give resistance and then ask the patient to move. While you're doing this, palpate the TMJ. Check for tenderness in the TMJ and check whether there is deviation or not. Okay, then here if there is any kind of crepitation or sound or clicking noise, sometimes the noise is not very evident, but you can palpate it, but you cannot hear it. At that time, you auscultate it. Alright, then examine the muscles of mastications. Muscles of mastications are examined bilaterally. You will have to ask the patient to clench tight and then palpate the muscle. Mostly palpation is done in the middle index finger. Check for the tenderness and consistency. Okay, the muscle will be taut and tender in case of the trigger point. Check for occlusal evaluation. Check if there is any kind of filling, high points is there, malfitting processes, check for that. Check for interarch relationship, whether it is normal or not. Check for wear facets for bruxism. Do the cervical examination. Cervical examination should also be done bilaterally. Check for all the cervical muscles, sternocleidomastoid, palpate it, check for the tenderness. As I mentioned earlier, TMJ problem, occlusion and cervical pain are all interrelated. If there is any problem in one of these, the other is automatically affected. So you need to examine all of the three. Then also evaluate the psychology of the patient. This begins as the patient enter into your office and you start to talk with it. Try to evaluate, see the anxiety level. Okay, ask the patient regarding the sleep, if any sleep problem is present or not. Regarding the anger management of the patient, ask for bruxism habit, fear. If the patient is any kind of muscle medications like antidepressant or something like that. Evaluate all the psychological factors. Okay, then we come to internal derangement of temporomandibular joint. Now this is one of the etiological cause of MPDS and it is also a separate disease entity. That's the reason why we need to know it. So what is exactly internal derangement? It is a dysfunction or disruption in the internal structure of the TMJ in which the abnormal relationship exists between the disc, condyle, fossa and the articular eminence. Okay. Now its etiology could be because of microtrauma or macrotrauma. Now both of this could result in stretching and tearing of the retrodiscal ligament. As I mentioned earlier, okay, if you see in my earlier lecture of temporomandibular joint anatomy, wherein I have described the anatomy of the articular disc, it has three parts. The anterior zone, the middle zone and the posterior zone. Posterior zone is also called as retrodiscal ligament. It is a bilaminar zone. It is highly innervated and vascular zone. So if there is any kind of stretching or tearing of that, there is severe pain. Okay, because of this constant stretching and tearing, degenerative changes also take place in the disc, which eventually result in symptoms like pain during function, limitation of mouth opening, and mastication and cervical tenderness. Then internal derangement can be of four types. Most commonly, the disc displacement is in the anterior medial direction. The disc displacement could be with reduction and without reduction. Or they could be structural abnormalities seen in the articular surface like adhesion, alteration in form, or systemic joint disorders like rheumatoid arthritis. Okay, as you can see in this picture, will mimic a normal TMJ joint movement. In a normal TMJ joint movement, the mediodiscal relationship with the condyle is almost constant in all range of motion, whether you're opening or you're closing, the condyle rests on the middle part of the disc. and disc and the condyle move in toto and glide around the surface of the clinoid cavity. Alright, but what happens in case of anterior disc location with reduction? As the name suggests, there is anterior dislocation, that is the disc is moved anterior to the condyle, hindering its movement. Okay, with reduction, that means it is moving anterior, at the same time it is going back. So there is the disc move in an on and off direction, moves in and on of the condyle as the condyle translate. So when you try to open the mouth, the disc come anterior to the condyle and the condyle hit onto the posterior laminar zone, resulting in pain and clicking. When you try to close the mouth, the disc again move over the condyle and the condyle moves to its normal position, producing a reciprocal click. So here the disc move on and off the condyle. Whereas in case of anterior displacement without reduction, as the name suggests, the disc does not move. The disc comes in forward of the condyle and get locked, because of which when the mouth is open, the condyle hit to the posterior aspect of the disc. So the mouth opening is restricted in this case, and you have a click, you have a restricted mouth opening, and then there is pain. Okay, when you try to move the condyle behind, the condyle presses onto the disc again and moves. So the range of motion is restricted in case of anterior disc displacement without reduction. So what happened, on one side you're not able to rotate, the condyle is not able to rotate, the other side the condyle rotate. So when you try to open, your jaw move towards the affected side. Alright, so there are certain things that you need to keep in mind in case of anterior disc displacement with reduction, is that it is a unilateral condition. Alright, there is limited mouth opening, there is mild pain associated with mouth opening. There is deviation of the jaw on the affected side because the condyle is not able to translate and rotate on the same side, resulting in deviation to that side. The other side can work perfectly alright. The lateral exclusive movement are hampered, that is, are less on the contralateral side, but they are normal on the ipsilateral side. Alright. Then we move on to the treatment of MPDS. The first thing that you need to do is the pain management. Obviously, the patient is coming to you because the chief complaint is pain, so you need to address the pain. You could start with medication like non-steroidal anti-inflammatory drugs for a week or two, or muscle relaxants for 7 days to provide symptomatic relief. Or you could give intra, if you have a proper trigger point or you have identified a trigger zone, then you could give intramuscular local anesthetic injection like 2% lignocaine or 0.5% bupivacaine. Auriculotemporal nerve block is also effective in case of intrinsic joint disorders. Now, how do you give an auricular temporal nerve block? You'll ask the patient to open the mouth as wide as possible. You will insert the needle at the junction between the tragus and the earlobe, okay, wherein you are going inside medially, forward and superiorly. You will hit the glenoid fossa, retract a little bit, and you will deposit the local anesthetic solution in the superior joint cavity. Then the other treatment modality is physiotherapy. Now, physiotherapy can be into a variety of form, like heat application, 4 to 5 times a day. For 20 minutes you can apply. It causes circulation in that area, remove all kind of metabolic product and inflammatory product from that area. Ultrasound is also a form of heat application in deeper tissues, where you give 0.5 to 1 watt of the cycle every alternate day. Massage in that area. Cryotherapy, that is cold pack compression. Now, cold, it increases the pain threshold. Okay, it affects the pain pathway, increases the pain threshold. It also decreases the concentration of histamine. Okay, does decreases the pain. Use of vapor coolant spray. Electrogalvanic stimulation. Okay, you increase the action potential. You stimulate the muscle by increasing the action potential to activate the injured muscle. Around 60 cycles per second. Okay, you do this. You use TENS, transcutaneous electrical nerve stimulators, and active physiotherapy exercise. Jaw opening and closing is a must. The next treatment modality is stress management. Stress management could be done by the help of biofeedback device. Now, these devices are visual as well as audible. So the patient can see the changes and hear the changes and relax himself. Alright, you could use acupressure, yoga, hypnosis, medication and deep breathing exercise to decrease the tension. The other treatment modality is intra-articular injection of hydrocortisone plus 2% local anesthetic agent. Now here, in this case, you will insert the needle, you will give hydrocortisone, 2 mg of hydrocortisone along with lignocaine in the superior joint cavity. Here also how you will give between the tragus and the inferior alveolar in your lobe of the ear. You will insert into the posterior of the condyle into the superior joint space. After this, you ask the patient to do physiotherapy exercise. You can also give occlusal splint. Now, occlusal splint are basically made on the maxilla and cover the incisal and occlusal surface of the maxilla. Then they have a table on the singular surface of this anterior region. Now, this flattened table area will disengage the mandibular incisors. While when you disengage the mandibular incisor, the muscle automatically get relaxed. So this will prevent hyperactivity of the muscle. Thus, it will also act as a cushioning effect. It will prevent wear facets on the occlusal surface. Alright. Then the other treatment modality is temporomandibular joint arthrocentesis. It is nothing but a lavage or irrigation of the upper joint cavity. Its objective is to improve the disc mobility, eliminate the joint inflammation, remove any kind of resistance that is present in the condyle translation, like any kind of adhesion that is present will remove it. It eliminates the pain. The indication is in localized TMJ pain, where the patient is saying, yes, I'm having pain in the TMJ. In case of acute limitation of motion and inflammation, limited improvement when medications have failed. When you have tried to use a conservative approach and these are failed, then you opt for arthrocentesis. It reduces the joint friction, releases fine adhesion, re-establish the range of motion, it evacuates the debris, the medication, okay, and pain and inflammation. It has a therapeutic effect, low morbidity and low cost effective. These are the minimal armamentarium that I use in arthrocentesis. You use 2 mg of dexamethasone, 2% lignocaine, 2 syringes, then you need a 19 gauge needle, ringer lactate solution and gloves. Okay, now before you start the procedure, you need to do surface marking. You will mark a line from the middle of the tragus to the outer canthus. Then on this line, you will mark 2 points, one posterior point and one anterior point. The posterior point is along this canthotragal line, 10 mm in front of it and 2 mm below it, whereas the anterior entrance point is 10 mm in front of the posterior point and 10 mm below the line. Alright. Now a 19 gauge needle is inserted in the posterior point, which will enter into the superior compartment, whereas another 19 gauge needle is inserted into the anterior point. Now this second needle is used to remove the ringer lactate solution. From the first, that is the posterior point, you will insert the ringer lactate solution for irrigation, and from the second point, the solution will come out. 200 ml of ringer lactate solution is lavaged through the joint space. Okay, on the termination of the procedure, you will use 8 mg of dexamethasone is injected into the joint space, and mouth opening exercise are advised for 2 weeks. Now this figure show you the step-by-step procedure that is taking place. The surface marking, the giving of the auriculotemporal nerve block, the 2 points that are marked, the posterior point and the anterior point, the needle are inserted, the lavage is done, and you can see the fluid coming out from the other side. The mode of action of this. The lavage of the upper joint compartment of TMJ forces the disc from the fossa. It releases it. It removes the adhesions, washes out the debris, decreases the intra-articular pressure whenever the joint is inflamed. It allows to rehabilitate the movement, which is the hallmark of joint health. The another treatment modality is use of TMJ arthroscope, which is a newer advancement. It uses a fiber optic endoscope to enter into the superior joint compartment. It not only helps us to diagnose the temporomandibular joint disorder, but also help us to treat the disorder. You enter into the joint compartment through the endoscope. You will get some attachment of surgical instrument to irrigate or to remove the adhesions, and you could do the surgically endoscopically. Very minimally invasive procedure, but you have to acquire skill to do the procedure. Then we come to the surgical modalities for TMJ dysfunction. Okay, like condylar shape or arthroplasty, wherein in severe joint adhesion, you actually can remove the condyle, okay? But the disadvantage of this is that there is occlusal is hampered. The jaw deviates to the site where you have operated because you have cut the condyle, all right? So these things are the limitation. Or you could do an eminectomy to facilitate the gliding of the condyle. Okay, if the condyle is getting locked into the eminence, you can do eminectomy. Or last surgical resort could be disc surgery, which is done in case of disc perforation. You could use and close the perforation either with autologous material like dermal graft or collagen, okay, and you can build up the disc. But keep in mind, the success rate of open joint surgery is 70 to 80% greater than disc surgery. But these are termed as a last resort. When all the conservative treatment modality doesn't work, then you opt for these resort. So in conclusion, I would like to say that temporomandibular joint disorder are among the most misdiagnosed and mistreated maladies. A lot of research is going on. Probably the most beneficial aid in the diagnosis is proper and complete history and examination. The treatment of MPDS involves many different modalities, but definite therapy always involves elimination of the cause, that is the stress or the occlusal discrepancy. You need to treat the cause to treat the condition. Thank you.